37 weeks. The bed rest lasts 2 weeks. The BPP has changed from 8 of 8 to 6 of 8. So what brings your attention as a nurse?
It's getting worse.
We have a worsening BPP. Anything else? She's been treating it conservatively the last couple of weeks. Honestly, for me, as a labor and delivery nurse, this also concerns me because she's technically preterm. 37 is pretty close, but again, that baby may need a little bit more resuscitation. And this baby is not tolerating the apartment. We need to move out of the apartment. Vag exam, 2 to 3, 75 and -1. Notice I didn't say anything about contractions. So we would not consider that latent phase. Because she's a multip, her cervix could be that all on its own. She could have had that for 2 weeks. Okay? I didn't say anything about contractions. So the question about how to help determine what phase of labor you're in, it's a combination of a lot of things. Contractions, how you present to yourself, vaginal exam. That helps determine what phase of labor you're in, okay? So in this situation, they're going with Pitocin. Notice no Cervidil, no Prepidil, no Cytotec, because this is what we would call favorable cervix. The baby is nice and low already, even at 37 weeks, okay? We can be very precise with that. And she's had a baby before, so I can turn that off if the baby is in distress. I have better control over that. The physician decides to do an amniotomy. Can they do that concurrently? Yes, but that means the labor is going to happen quickly. And again, we're moving quickly because of the preeclampsia. She's a multip, she's favorable. Now, in this situation, can she get an epidural? In some cases, if the patient's moving very quickly, there may not be time to get an epidural. So that's one of the factors to consider if your patient's asking for an epidural. If she's gonna deliver in the next 20 or 30 minutes, it may not make sense to get an epidural. But some women like that sense of control when it comes to transition and pushing. So ultimately, it does tend to be a decision with the provider and anesthesia, okay? So if she's in active phase, she could have an epidural. A lot of times the provider, she may have 0 contractions, but the provider says, you know what, you're gonna be on Pitocin, you want your epidural, you can have it whenever you want, because we're just crank up the Pitocin if we need to. Now the issue about cranking up the Pitocin, the more Pitocin you're on longer, you can have more risk factors after delivery. Okay, question?
So why is the amniotomy?
Because the doctor wants to get things moving along toward delivery. It's just another method of, so these are not necessarily, you don't necessarily do them together. They could be done separately, but they could come together. The whole thing about amniotomy, those were committed to delivery. So she delivers at noon on Friday. We just started her on PIT and that's a pretty fast labor. And then no MAG after delivery. Again, the decision that determines whether or not she gets MAG is often her symptoms in terms of her blood pressure, her headache, the edema, what her urine does, and again, it may just be a watch, wait, and see. So being on Pitocin is not gonna make the preeclampsia worse. Any questions on that? So this was no MAG. And it's because it was mild preeclampsia. She was on bed rest. We were concerned about the baby, but again, we may just watch, wait, and see. Okay? All right, so talking about MAG sulfate, I just wanna make sure, this is for toxicity, low reflexes, okay? So if we're giving MAG for preeclampsia, what's a therapeutic effect here is we wanna see a decrease in the hyperreflexia. So in other words, she was +4, and we wanna see that go maybe to +2. Does that make sense? That would be a desired effect of the MAG sulfate, because it's a CNS depressant. We should see a decrease in her symptoms, so that would include what?
resolution of the headache. Drop in edema.
Urine output and to some degree edema. We won't see those change dramatically. The big thing we need to be really careful about with preeclampsia when she's in labor, remember we're giving her IV. And so we can easily push her over into pulmonary edema really quickly. So again, when I come over here, these are all the same. So being flushed, hot, nausea, vomiting, muscle weakness. Again, generally when you're on MAG, you're not getting up, moving around. In terms of toxicity, the same, but again here, you can see if I have respiratory depression, and again, I'm giving fluids, and so I can get into crackles, a productive cough, that would be bad here. And why do I bring it up here? It's because we often see it more here than here because we turn this off. You don't get MAG during postpartum when you're getting it for preterm labor. But preeclampsia, we often continue it. And so you're gonna see sometimes some more issues with toxicity. So again, I look at pulmonary edema, I look at decreased urinary output. You can have bradypnea. Hypermagnesium. That's a hard word to say. Okay? Is there any question about that? Yeah.
What is the AA after the decreased BP column AA?
Headache.
Oh, okay.
Sorry.
Read it.
Headache. So on MAG, some of the symptoms will get better, but you might change them for different symptoms from the MAG. But better to have a little bit of feeling really hot and flushed, so you might have to make the room cool. It's better to be flushed and hot than have a seizure. Okay. All right, over here on our far side, this is like worst case scenario. 25 weeks, gravida 4, para 0. She was admitted from a rural area. Blood pressure is 170/90. She has +4 reflexes, visual disturbances. So she is sick. She has epigastric pain. That would make me concerned about abruption. She has MAG at 2 grams an hour. Honestly, again, if things are getting worse, they don't keep bumping up the MAG because it's just gonna get worse and worse and worse. We're gonna go quickly into seizure. So the physician makes a decision about an emergency C-section at 25 weeks, And again, that baby is really close to viability. So that baby may not make it, will be in NICU for quite some time. This patient, because it's so severe, may not go to mother baby, may actually stay on labor and delivery and have mag sulfate after delivery, but may even end up transferring to ICU. So all the folks who really want to do critical care and you hate OB, this lady's probably going to come to your doorstep. So you'll have to do bundle checks on her while you're also titrating your drips and keeping her pressure stable. So take care of her arterial line. All right. So I brought up the preeclampsia case study. I'm not going to go through the whole thing, but I just kind of want to show you what this is. And there's some others, gestational diabetes. And so Ashley Cash, 42-year-old female, she's gravida 1, para 0 at 38 weeks, and she had prenatal care. So the idea is she's very in her age, and that is her first baby. And so you kind of read through these little images. You can click on them and actually see some pictures of things. So if you're not familiar and you just want to revisit exactly the definitions of different types of edema. But you'll notice in the questions that they have select all that apply as well. So this one has 14 pages. Again, there's some of the questions I don't agree with. So you may have to get the answer to get, to progress in the case study. I think it's just extra practice. And if you ever do a case study and you're like, I don't understand that, or I don't know why they the answer is the answer, just shoot me an email and I'm happy to talk through it. But I wouldn't get 100% on this case study, I would miss some questions. Let's see if I can get to there's one in particular that I think is a horrible question. It didn't say anything about, I don't remember her saying having a molar pregnancy. I'm trying to read this super fast. Oh, clonus. I didn't bring up clonus. You guys know what clonus is?
It's like the reflex when they.
Yeah, so what you do, usually we do it on the foot, so you rotate the foot and then you jerk it back really quickly, and then you have beats of clonus. And so in that situation, preeclampsia number 3, when you have beats of clonus, again, that's a huge red flag for potential for seizure. And so on mag sulfate, we would want no clonus if you're on mag. See, that's the thing. These are actually good because they help me think of things. Let's see how I did. Am I right? I probably missed the select all that apply. Some correct choices were not selected. She wasn't pregnant before. We'll do this one. I did get that one right. Yay, I made it. And so it gives you some rationales. They have updated some of them so they're not as clunky in some of the other areas. But you can see it kind of gets a lot of reading. It's not something you want to do the night before the test. Yeah, it's not here. So it's later on. One of the statements that they make to the patient about preeclampsia, I just didn't really like it. So again, something to play with, something to practice with, but I wouldn't get so fixated on it. Like, you know, it's not the greatest thing since sliced bread. The other thing I wanted to bring up was our MAG and our PIT questions on Moodle. So I have this question. Mag sulfate, administer a mag sulfate infusion for a patient with preeclampsia. You have a premixed bag, 40 grams per liter. The order reads administer a 6-gram magnesium sulfate bolus over 30 minutes, and then administer mag sulfate at 2 grams an hour. Total IV fluids should equal 125. So in this scenario, there is no piggyback. They're using the big bag, and they're given the bolus from the big bag. And you're gonna, once the bolus is in, then you change the rate to the continuous infusion. So for example, the bolus, and this is how I did my conversion, and so I knew that I needed to give 150 milliliters. So if I'm gonna give 150 milliliters over 30 minutes, then I know my infusion rate for the bolus is 300 milliliters per hour. On the pump, I'm gonna set it so I'm only gonna infuse 150 milliliters because it will beep, and then I know to change the rate. Does that sound cool with what you remember about piggybacks? And, you know, I think again, a lot of people, a lot of our smart pumps automatically switch the piggyback over to the primary, and you don't have to do anything. In this situation, as a nurse, you'd have to do something, okay? And so to administer the mag sulfate at 2 grams per hour, what would you set as the infusion rate for the mag? And notice here, I did it a little bit differently. This is a pretty common concentration. So remember Pitocin? I mentioned, you know, sometimes it's 20 units in 1,000, sometimes it's 30 units in 250. Mag sulfate, you don't see quite as much variability with that, okay? And also notice that with this, I just kind of did the formula version. So you have to cross multiply. So 2,000 divided by 40 will give you 25 milliliters. No, that should be 50, right? That should be 50. Yeah, this is right, this is wrong. So it's 25 milliliters per gram. And so this is another situation of when you have IV fluids and you need the IV fluids to equal 125. If I have MAG going at 50, then my primary fluids, because I always have primary fluids going with MAG. I always have primary fluids going with PIP. So I have multiple IV fluids that I have to keep track of. So then there's an example of mag Pitocin and fluids. There we go. situation, the patient is on 2 grams of mag. We're supposed to start Pitocin at 1 milli-unit per minute and then increase to 2 milli-units per minute every 20 minutes until you have an effective contraction pattern. The total IV fluids should equal 125 milliliters per hour. So this would be an example of a math problem. There's multiple steps within the problem. So what is the rate in milliliters per hour of the magnesium sulfate? The scenario tells you that Pitocin's running at 14 millunits per minute. And so again, you have to know the concentration, and in this scenario, the concentration that's being used is 20 units with 1 liter. We could change that and change that concentration of Pitocin. Again, you can see where if I have 3 different IV fluids I have to adjust, then the Baptist model of mixing Pitocin is much easier because it's 1-to-1, and I don't have to think about, the pit's at 14, the fluids will be at 14. Okay. So I'm gonna let you, I don't wanna go through this today, but I'll kind of play with that a little bit over the weekend. And if you have questions, but this is our math for the test on Tuesday. It's the Pitocin mag and then reconstitution of solution, which should be reviewed for you from tomorrow. Is there any breaking questions I can answer about the math? I would just be real careful, make sure you're kind of calculating things correctly. And again, when we do Pitocin in labor and delivery, when she's pregnant, prior to delivery, it's millunits, we use millunits per minute. We don't really worry about millunits per minute after delivery. All right, I feel like I have to death preeclampsia, preterm labor. Is there any other questions about those 2 concepts? Because the other things we're going to go lightning fast. We will not be here to 2:20, so I have some practice questions. All right, on to OB emergencies. So talking about non-reassuring fetal heart rate, that can be for anybody. It does not have to be somebody with a pre-existing health condition. So this is for a preterm labor patient. This is for normal, healthy, no risk factor patient. This is for preeclampsia patient. So when you have non-reassuring fetal heart rate, again, the nurse is usually the one that initiates the interventions. And so you'll notice this term, intrauterine resuscitation. And the idea is, again, that is my priority. So in other words, if my patient is in pain, I get that, but if her baby's in distress, I'm sorry you're in pain, but I need you to turn. I need you to move over on your side because your baby's heart rate is 80. So the first thing we tend to do is change position. The next thing is we look at blood pressure, so getting her vital signs. Then we would stop Pitocin. So remember on the one slide it has badge exam before Pitocin. We stop the Pitocin first because Pitocin is causing a stressor and you want to take away all the stressors. We would give medication to decrease uterine activity. I can do this independently as a nurse. This is dependent. I need an order to do it. Increasing our fluid rate. Again, sometimes we'll go ahead and bolus, and the reason we do that is to make sure she's well hydrated. The other thing is if we need to go to C-section, we've already started our fluid bolus getting ready for surgery. And then we'll do an assessment for prolapse cord with a badge exam. So that's really the need to know about that. Shoulder dystocia. Shoulder dystocia is really scary. The head is out, but you can't get the shoulders out. So she delivers the baby's head. And so the baby has a lot of risk for arm and shoulder damage and also neurological damage. And the key thing with this is often the patient's in an upright position when they're delivering, and immediately it's very clear there's drills and they'll say we have shoulders or we're at risk of shoulders, and everybody knows what they need to do. The very first thing, again, you're going to lower the head of the bed. So we actually will want the head of the bed down. She needs to pull her legs back, and you're going to do McRoberts maneuver, and you need to know what that is. And so this is what it is. She flexes her knees back on her thighs, and usually the nurse is putting pressure on the symphysis pubis to dislodge the shoulder underneath the symphysis pubis bone. it is not optimal. And it can be really scary. And so one of the things you're concerned about is how long it took to deliver the rest of it. So you might notice when the head's delivered and then how long it takes to get the rest of the body. Kevin, did you say you had a shoulder dystocia? And so how long did it take? Did they do this?
It was pretty, I feel like she was in that position
Already?
prior to that.
Okay, did anybody get on a stool on top of her?
Stools were broken out.
Yeah.
And I didn't realize that was like, I thought the nurse might have just been like short or something.
No.
I didn't know what they were doing. I mean,
No.
they're already like, had her legs like
Yes,
pinned pretty
yes.
far back.
And they get really pushy, like, okay, we really need you to push, like, you need to push as hard as you possibly can. The mood changes pretty rapidly. But yes, the stool thing, and then we normally do not push on mom. Like, as a nurse, I don't touch mom when she's delivering the baby. But in this situation, and you don't push on the fundus, you push on the symphysis pubis. So it's very low, because literally you're pushing on the baby's shoulder, and that's how the baby's clavicle gets fractured. So,
Is it normal to do an episiotomy? 'Cause that's-
we do anything we can to get that baby out, yep. They can't really do forceps or vacuum on the shoulder, like the head's out, so there's nothing to apply to get, but yeah, they try to make as much room as they can, and the physician sometimes will reach in as well, and also, sometimes they dislocate a shoulder to get the shoulders to come out. It's better than a dead baby, it is, yeah. So there's some really, bad things in the book about what happens if this doesn't work. Don't read that, you don't need, you got enough on your plate, okay, it's just bad, just leave it at that, okay? So again, this is called McRoberts maneuver. I would definitely put that in the toolbox, it's a pretty common thing, common question on NCLEX review and that sort of thing. Prolapse cord, again, the big thing is to recognize it immediately, and so the patient might call you as the triage nurse and say, something's hanging out between my legs. What? It's probably the umbilical cord. So we'll put her in a knee chest position. If you do a badge exam and the cord comes out in front, you might feel pulsation there rather than something hard as the baby's head. I will never forget when we had an ER resident come in through EMS. His wife, water broke at home, had a prolapsed cord. They recognized it right away, and so they came in on the gurney together. Like, she was on her back and he had his hands up there keeping the baby's head off the cord, and they went to the OR together and they were all fine. But again, it was that prompt recognition that there was a cord prolapse. So this knee chest position is done to try and get pressure off the presenting part off the cord. And then again, usually it's an emergency C-section. The other patient population that we can see this in is if the baby is breech or has some type of malpresentation, because the cord will kind of get in front of the presenting part. Preterm patients are high risk of prolapsed cord because the baby's not low in the pelvis, so we're watching for that as well. So amniotic fluid complications, we have oligohydramnios, which is too little fluid. Polyhydramnios is too much fluid. In oligohydramnios, when the water gets broken or if the water breaks, we are real concerned about variable D cells. Polyhydramnios, believe it or not, can sometimes be worse because there's so much fluid, and if it comes out rapidly, the baby's position gets wrong. And so it's like they get kind of stuck in OP because it's like the floodgates open and the baby comes down too quickly. Sometimes that's how you get like the hand and the head together in mom's pelvis. And amniotic fluid embolism is very, very rare. Unfortunately, we are seeing more of these. In most cases, we are doing a really good job. We're actually helping women survive, but the mortality rate, it used to be like 90%. And so it's very sad. We think it's some type of anaphylactic reaction which causes something in the amniotic fluid, gets into the maternal bloodstream, and mom has an immune response to it and goes into organ shutdown. And so it mimics anaphylaxis. And so we kind of manage it as anaphylaxis. We try to keep the organs perfused as best we can, but sometimes we do everything and nothing works and mom passes away. So it's a very scary situation. You're at risk of having it if you've had any type of coagulation disorder or autoimmune. C-sections and then any kind of invasive procedure with amniotic fluid. So like amniotomy might put you at marks for having an amniotic fluid in the puss. Uterine rupture, again, very rare but catastrophic. With the uterine rupture, the muscles actually tear apart. Yes, sir?
For the amniotic fluid embolism.
Yes.
It's pretty bad. I know that
Yes.
all there for the incident.
It depends on when it happens. So, my personal experience with it, the baby was fine, but mom died on the table. So, we had one last year, and baby was fine, but mom didn't make it. It depends on how they catch it. A lot of times it happens to at the time of delivery, so you deliver the baby, and then delivery is the riskiest time where that fluid can get into the maternal bloodstream. For a uterine rupture, it's usually from laboring from and you have a classic C-section, so that long vertical incision on the uterus, but it could also be motor vehicle accident, trauma. If you're given too much Pitocin and not monitoring your Pitocin, if you have an overdistended uterus, so multiples, you have polyhydramnios, and then if they do a version, so this says external or internal version. I would like for you to promise me that you will not read the section about internal version, okay? I talked about external version, far more common. Internal version is usually something with multiples and turning the baby, don't go there, okay? But basically with a version, you're pushing on the uterus and doing all these things, and if you push too hard, you can actually rupture the uterus. The other thing that can happen sometimes, you can actually have a uterine inversion, and it's where after she delivers, the uterus will come out inside out. That's also a very rare bad thing to happen, so that's one of the reasons why we want to make sure that we always do a bimanual support of the uterus, or we massage the uterus after delivery. So DIC, I talked a little bit about that. Sometimes we know it's coming, sometimes we don't, but I would say one of the key things that cues us in is this combination of bleeding and blood clots and the change in mom's vital signs. So when we suspect it, they will draw blood work on her to check her coag factors. Sometimes they will replace those depending on what they are. This can happen during labor, it can happen postpartum, and again, my experience has been more hemorrhaging than clots being a problem. And so we really have to, we get mom into fluid and electrolyte imbalance because we're putting so much fluid in and blood in, it's kind of coming out as quickly as we're putting it in. And so she gets into a lot of imbalance, so we usually end up sending those patients to ICU. CPR, with CPR, the big thing about CPR is it's not going to be enough to support the baby. You may need to have the patient and displace the uterus off to the side so that the chest compressions can provide adequate circulation to mom. But we're not doing CPR to save the baby. With CPR, if you needed to put an AED on mom, you want to make sure that there's nothing metal on her. So if the baby had a scalp electrode, that scalp electrode needs to be removed before you use an AED. They need to make a pretty quick decision about whether or not they're going to try and deliver and do a perimortem C-section, which means that mom may die, but we can deliver the baby successfully. When I've only had to do CPR once on a pregnant woman. It was from a car crash, and it was kind of pointless. She was already gone, and the baby was gone. It was really sad. The other thing is, if you have a pregnant woman who's choking, we do not do the Heimlich maneuver on pregnant, because again, you don't want to push on the uterus. So we start with conscious choking with pregnancy. You actually start up higher with chest compressions to dislodge. If it becomes blocked and she becomes unconscious, we go into CPR. So that's a really sad